Good morning, everyone. It's such a pleasure to be here this morning. And I thank Dr. Lalit Verma for inviting me and for Ajanta for hosting this wonderful symposium. So, I'll be speaking on a few complications of cataract surgery, time permitting. So, the lens may be the focus of a cataract surgery, but the retina sometimes becomes the ultimate judge of its success. So, a case in point here is a 65-year-old lady, a well controlled diabetic with no diabetic retinopathy, who had a vision of 6:6 after an uneventful cataract surgery. However, 3 weeks post op, her vision deteriorated to 6:24 and she had a significant amount of metamorphopsia. Yes, you guessed it right. This patient had a cystoid macular edema where you see the yellow spots, yellow dot sign at the fovea, along with cystoid spaces, and the OCT is telltale, a typical OCT for cystoid macular edema. Now, to give you an overview of cystoid macular edema following cataract surgery, it is the most common cause of reduced vision after uncomplicated cataract surgery. Clinical CME is symptomatic vision loss that is 612 or less, and that would be present in only around 0.1 to 2% with modern phacoemulsification surgery. However, there's an entity called angiographic CME, where if you do an angiography, you will see the petaloid leak at the macula. These patients may not be symptomatic and may not have OCT features of CME. This is called angiographic CME, and this would be present in a larger percentage of people, that is around 20 to 30%. Now, the most important thing to remember about pseudophakic CME is that the onset of this condition is later on in the course of the after the surgery. That is around 3 to 6 weeks post-operatively. Generally, it peaks at around a month's time. So the patient would have good vision initially and then would gradually have decreasing vision. The foremost risk factor for this is diabetes, pre-existing uveitis, vein occlusions, epiretinal membranes. Of course, an eventful surgery like a PCR, a high phacoenergy, or long duration of surgery also contribute to this. So, inflammation due to surgical manipulation is what causes CME. It causes release of prostaglandins and a breakdown of the inner blood retinal barrier. Now, any patient with unexplained poor vision after cataract surgery should have an OCT. Many times, the cystoid spaces may not be visible clinically. It's only the OCT that will tell you. Now, the CME may not show that typical book pattern. So, the pattern of the edema starts in the inner nuclear layers here, as you can see here. It then moves on to the outer plexiform layer, and then you get the edema here, that is the subretinal fluid. So, generally, in a full blown CME, it's a tri compartment edema, that is the inner nuclear layer, the outer plexiform, and the subretinal fluid. And these may come on gradually as the disease progresses. Management of CME is with NSAID drops. So, you could use Nepafenac, Ketorolac, Bromfenac. The favorite of all, there have been no studies which have actually been able to tell us that which drug is better. Nepafenac does have a better penetration and efficacy, but otherwise all of these would work. So NSAID eye drops plus steroid eye drops working in conjunction with each other would give you a gradual resolution of this condition in 1 to 3 months. If you're not getting a very good response, you could switch to dry fluprednate, which is a more potent steroids in unresponsive cases. However, you need to monitor the IOP. The steroids can be stopped after 2 weeks, but the NSAIDs need to continue longer. So, this was a patient who had a 1 month following cataract surgery CME. This is after topical Nepafenac drops. This is 4 weeks after the treatment. And this is 9 weeks after the treatment where the edema has completely vanished. Persistent cases are the ones which show no response even after 6 weeks. And these are the cases where we need to do something more. These can be taken up for periocular triamcinolone, that is subtenon Stricort, or intravitreal steroids, that is a dexamethasone implant, or intravitreal triamcinolone. Now, the role of anti-VEGFs is again a little controversial and debated. They do work, but generally we keep anti-VEGFs for recalcitrant cases because multiple injections may be required. And especially if there's a component of diabetic macular edema along, then anti-VEGFs work well. However, since it's an inflammatory condition, the first line treatment is with steroids. Now, routine prophylaxis of CME is not recommended in all cases. So, various societies like the American Academy and the Royal College do not recommend routine prophylaxis. It's only high risk cases like diabetics, previous uveitis, a patient who's had CME in the fellow eye, where we start preoperative NSAID eye drops. So, you could start them 3 days before, 3 times a day, and then continue after the surgery as well. Now, the important thing to remember is that diabetics have a 2.5 times increased risk of DME. And these could be diabetics with or without pre existing retinopathy. Always remember to prescribe artificial tears because NSAIDs cause a lot of drying. Counsel these high risk patients before the surgery. So, any diabetic, you need to tell them that there is a risk of CME happening. And another important point is to prevent chamber fluctuations during surgery. So do not allow your chamber to deflate and inflate. Put in viscoelastic before you come out because the tractional component also leads to CME. Epiretinal membranes, again, people ask that does every epiretinal membrane need to be peeled to get rid of CME? No, a thin epiretinal membrane like this can have CME coming in and then respond to dexamethasone implant. However, the risk of recurrence is much more when there is a epiretinal membrane. So, in recurrent cases or whenever there's a recalcitrant CME that is persisting beyond 3 months, and you see a tractional component like this, these are the patients where we have to do a pars plana vitrectomy with the peeling of the epiretinal membrane, sometimes combined with an ILM peeling. Another important factor is a vitreous wick, where you see a strand of vitreous going into the wound, and such cases would need a YAG vitriolysis. So, this is chart that we follow in our practice for the management of pseudophakic DME. Quickly coming to pseudophakic retinal detachment, now approximately 40% of retinal detachments occur in the non phakic eye. And at 10 years, the risk of retinal detachment is 5.5 times in patients who have undergone cataract surgery. So the risk continues. And why does this happen? This is because of the mechanical effect of cataract removal, structural changes in the vitreous, and complications in the surgery. So the cataract causes PVD, which causes retinal tear. This PVD, again, there are structural changes in the vitreous which lead to PVD. And of course, if you've had a complicated surgery, you can create tears at the vitreous base and cause retinal detachment. Patients who had high myopes, history of retinal detachment in the other eye, and younger patients who would have a very acute PVD and develop breaks. So 50% of the attachments occur within the first post-op year, 16% during the second year if you've had a complicated surgery. And following YAG capsulotomy, they would occur in the first 6 months. Now, a good retinal examination, as far as you can see through the cataract, is imperative. And if you see any breaks or lattice, it is important to treat them before surgery, or if not, then schedule a retinal examination immediately after the surgery. I'll just skip this. These are the different so the management is with vitrectomy generally in pseudophakic detachments. And the my penultimate slide is that adequate patient counseling following cataract surgery should be done to increase the awareness of the symptoms of detachments. Be careful in high myopes. Uh, Whenever there's a patient who complains of floaters after cataract surgery, generally we tend to disregard them. But floaters, especially if combined with flashes, do look at the retina in the periphery. If not, ask your retina colleague to look at the periphery to rule out any PVD which has caused breaks. Other complications, I don't think I'll have time for. Now, what I would like to end by saying is that every cataract surgeon should have an arrangement for referral, a pre existing arrangement for referral with a vitreoretinal surgeon. So you must already have that working relationship, establish a protocol regarding the management of a patient with retinal complications. So recognize retinal complications early, manage them, and refer them early to prevent fallen vision of the patient. Thank you so much.